And welcome everyone to another wonderful episode here at Just Podiatry. I have a fantastic case for everyone. I think a lot of people are going to be able to relate to this particular case because there's a lot of people out there with flat feet. Let's talk a little bit about flat feet. Flat feet, also known as pes planovalgus deformity. That's kind of like the complex term. You can have flexible flat feet and you can have rigid flat feet. We're not going to really talk about that. We're going to talk about the clinical presentation today. We have a very young patient who, during the course of the last, we'll say,
2.5 months.
2.5 months has been battling, right, medial ankle pain. Okay. The problem is that she does have a boot and she's been inconsistently wearing the boot. And every time that she wears the boot, the ugly boot, the pain goes away. I've seen this patient in the past. It's been a very, very long time, but she, when she originally came to see us, she wanted a new pair of orthotics, which we went ahead and fabricated. And she's been doing really well with those orthotics, custom made, custom molded orthotics. And they definitely help. But the problem is that there's a condition called the posterior tibial tendon dysfunction. The word dysfunction means that something is obviously not working correctly. Whether it's dysfunction, whether it's an inflammation, a tendinitis, or a degeneration, tendinosis, or even the dysfunction, the patient presented to us today with pain, right? And she's going to be going away for the summer for several months, and she wants to make sure that she is a-okay. So let's take a look at the clinical presentation. A very, very clear flat foot. People, let's take a look from not only from the side, you can see that the medial aspect of the ankle is actually turning inwards. That's what we call heel valgus. Same thing goes for the right, maybe a little bit more so on the left than on the right. Okay. Let's move back a little bit here, Elizabeth. Let's give people the front view. And as everyone can see, look how the ankle is actually rolling in, right? We want to, we would, want to put that's neutral. This is not, you see? So this patient is actually, have a seat here, please. She's very young. And the problem is that my concern at the end is that that tendon can actually get so inflamed, right, that eventually, look down, right, that people will end up walking like this. And when people, when that tendon, God forbid, it ruptures, then either you need surgery or you need surgery and then something to help the patient walk correctly. Like what? Like a brace. For how long? Maybe for the rest of your life, right? So, and we don't want that. So what we're gonna go ahead and do today is, we're gonna go ahead and obviously immobilize. We're gonna go ahead and immobilize the area, of course, because like I said before, and draw. The tendon runs right here with a couple of other tendons as well. Not only tendons, but really important neurovascular structures, such as a very important artery, vein, and nerve. Let's put that underneath. Thank you very much. Excellent. Okay. So here we have the tibia, which is the bone. And we'll make believe that this is actually the tendon. The tendon comes in, inserts here into the navicular. Okay, and the patient has pain, and I will ask the patient. We usually demarcate before.
Right there.
Okay, so we'll just go like this. How about here?
Mm-mm.
How about here?
Mm-mm.
How about here?
Mm-mm.
Let's go back here. How about here?
Right there.
How about here?
Right there. Ooh, right there.
Okay, how about here?
A little way.
Less?
Less than the other one.
Okay. X marks the spot. So the first thing I'm going to do is I'm going to go ahead and anesthetize the area. Okay. And I'm going to go ahead and anesthetize the area, right? Because, like I've said it before, PRP is uncomfortable. Okay, this is alcohol, and I'm gonna go ahead and use a little bit of lidocaine mixed with a little bit of Marcaine. We're gonna use a little bit of cold spray so she does not feel the stick. And I really wasn't, if the pain was more posterior here, I would probably defer the local anesthesia, but I know for a fact that we need to numb this area up here because it's really going to be uncomfortable for the patient. So we're going to go ahead and okay, you're going to feel, any allergies?
No.
Okay, you're going to feel a little bit of cold spray. Here we go. A little pinch and a lot of burning. A lot of burning. A lot of burning. Okay. Again, another pinch. Burning. A lot of burning. A lot of burning. 1 second. We always pull back here just to make sure, right? I said before there's a really important artery there. We don't want to inject into the artery. That's a no-no. And again, we're just infiltrating. We're over here now. And we'll go like this. Okay. Thank you very much, Lisbeth. Okay, and again, we don't inject the area. We're just trying to numb, and then there's going to be one more little stick. Okay. Right there. And this is a little bit of a more of a sensitive area. She felt that. And burning now. Here we go. Okay.
Yeah.
And that's it. Okay, we're done. So we'll give it about a minute, and during that minute, I'll go ahead and do what I do, what I love to do, which is educate. We are not doing the percutaneous microtenotomy. Historically, again, the dry needling procedure. We're only doing the injection. So we're not going to be fenestrating the tendon. There's no need. Part of the problem also is that we don't have, and there's no need for today, an MRI, because the fact that the patient does feel a lot of relief from using the boot, that tells me that it's most likely just inflammation, and that's about it. There's always a possibility that you may have some micro tears, right? I don't have MRI vision, but there's, as everyone may or may not know, there's a saying, you can't teach experience. So in my experience, I think that, injecting the tendon here with only PRP, with the immobilization and maybe a little eventual physical therapy and a pair of brand new orthotics, I think that she's gonna do fantastic. Okay, so we're gonna go ahead now and take our PRP. Again, PRP stands for platelet-rich plasma. What do we have in here? We have isolated from a great quantity of blood. We have isolated the plasma, the platelets, which contain growth factors, important cells, important proteins, and I can get a little bit more scientific. I'm not going to do that, but this is like liquid gold, right? Healing the natural way. I love it. Passion. Okay, So what we're gonna go ahead and do is the patient should probably feel.
I don't know, you're touching it. It feels like a tingly.
Right. So the difference, some people have the ability to decipher whether it's pain or pressure. And even, and I've said it before, even with anesthesia, sometimes the patient will feel some dull, achy pain in this area, right? Because we're not anesthetizing in the tendon. So if you do feel any discomfort, please let me know. Okay, it's a dull, achy pain.
Okay.
Just say, it's bothering me, and we will go ahead and stop there, and then we'll wait until that goes away, and then we'll infiltrate a little bit more. Okay? Okay. So here we go. Any pain?
Just the pinching.
Okay, here we go. Okay. So now what we're going to do is we're going to slowly start infiltrating, and we'll ask the patient, how do you feel? How do you feel?
Weird. It feels like a burning.
But is it pain?
No.
No? Okay. How about now? I like to infiltrate very, very slow because I want to make sure that we maintain all the PRP, right, in the affected portion, in the affected area. You're doing a great job with the camera, by the way. That's really nice.
Okay, that hurts.
Okay, so then we stop there. I'm gonna move a little bit back, okay? Tell me if you feel any discomfort here. How about here?
No, I'm okay.
You're okay there? Okay. You know, and again, we don't necessarily need to inject everything, right? There's no need for that. We're talking gazillion cells here. Millions and billions of just cells, right? Platelets. All of these platelets we're just pouring everything in there. Right?
Okay.
Yes?
Mm-hmm.
Okay, we're gonna stop here. Carefully just bring it out. Okay. And I can tell that's definitely enough because you can actually see, right? There's a big, nice little wheel there. And we're gonna leave it like that for a couple of minutes. Okay, we'll go ahead and clean our anatomical diagram here. Right? We won't touch this because I want all that plasma to stay there. Okay. We're done. Sometimes the patients after, I've said it before, when we turn off the camera, the patient will say, just, go ahead and take the rest and just infiltrate it, and we'll see how she feels about that. But again, more is not necessarily better in this particular case. I think the lesson in this particular video is for people with flat feet, aside from the conservative treatments, prevention is the key. I've said it over and over. Prevention is the key. It's a progressive structural / biomechanical problem that could have long-term complications and effects, like this, at a very, very, very young age, in your 30s, right? 30s. So she's very, very young, and if you don't take care of these problems early on, they can lead to major complications. And we do see a lot of people with flat feet that are totally and completely asymptomatic, but these are the cases where they're not asymptomatic, they are symptomatic. So like always, I thank everyone for watching. In closing, www.jawspodiatry.com. Please follow us on our Facebook fan page, Jaws Podiatry, our Instagram, Dr. Toe Jam, and last but not least, our YouTube channel, Jaws Healthcare. like always, have a wonderful day. So I just I'm gonna go ahead and edit this into the last part of the video. So this is actually this is one of 5 tubes that we isolated blood from the patient. And as everyone can see, we have our centrifuge right here. This is where we spin the blood, and this is, again, they just went ahead and they threw away 4. This is a 5th tube, so we had 5 tubes. And basically, as everyone can see, after we spin the blood, it separates into 2 components. And you have the top portion, which is, in this particular case, what's left, which is the PPP, the poor platelet plasma, and then we have the other component, the blood, on the bottom. So that's how it separates, and then we're able to isolate the PRP, the rich, not the poor, right? The PRP, platelet-rich plasma, not the poor platelet plasma. Okay? So there's a very, very big difference. PRP, the rich, and then the PPP, the poor. So I just wanted to add that to the closing, so everyone gets a better idea of what we do here with the blood, and this is definitely obviously the integral part of the procedure. So again, I hope you guys all enjoyed the video.